Check. Second तो critical है नहीं main check 1 2 मैं copy
Decades. Visceral leishmaniasis, also known as Kala.
everyone, we are starting, so please take a seat. Thank you very much. Yes, starting. Yes, starting. You are sorry. Yeah, please, please. Kala-azar.
Yes, we have the other colleague here. I'm looking for this digital health one because the other side,
Which one?
digital health, digital health.
Digital health.
The
Is the other one because Aki went to the other one.
Manisha. When is the video? It's after the after the dignitary speak, right? Yes, the video is there. Okay. Yeah, can you escort some of the people when they come in? Very good evening, everyone. My name is Suman Rijal. I am the Director of Communicable Disease and Surveillance at WHO CERO. And it's an honor and pleasure for me to welcome all of you this evening to this side event on sustaining gains, expanding horizons from a 20-year journey of regional Kala-azar elimination commitment and innovation towards a healthier South Asia through multi-disease elimination. A very long title. So essentially, it's so pleasing to see a lot of friends and colleagues who are here today, who have been with us throughout this last 20 years, and who have been a part and contributed to the success of what we will talk about today. I would just like to also relate to you some personal experiences. I started working in leishmaniasis since 1998. And I must tell you, the situation for leishmaniasis at that time was very challenging in our part of the world. Yes. So we were the epicenter for Kala-azar, and the epicenter, in fact, was in the state of Bihar in India, and also the contiguous regions in the neighboring countries, that was in Nepal and in Bangladesh. So at that time, since Kala-azar history, if you look at the history, we have been having Kala-azar epidemics since more than, it is, I think, the first recorded case was in Jessore, which is now in Bangladesh, and it is in 1824. So more than 100 years, we have been having Kala-azar outbreaks. And there has been horrific stories of that because we didn't have any treatments at that time. And we were not very dissimilar when I started in the 1990s. The treatments was very challenging. The diagnostics was very difficult. We will show many of these things during the course of this evening. So today we have come 2 decades since we signed the MOU between the 3 countries, a high-level understanding between the Minister of India, Bangladesh and Nepal, which was also facilitated by WHO, which committed to end and eliminate Kala-azar. So this was the WHO Southeast Asian region, was the first region in WHO who decided to eliminate Kala-azar. And though we thought it would be a very difficult and challenging task, but I think we are very pleased today to see where we are. Now, I would like to start by inviting our officer in charge of WHO CRO, Dr. Katharina Boehm, for her opening remarks, please.
Thank you, Dr. Suman. I actually don't want to say much except to welcome you all and to express my gratitude for being here for this important side event. I know we got a little bit delayed, but I feel this is very important. So thank you so much for the co-hosts of this side event for doing it with us, and especially, of course, to the government of Nepal and India. Neglected tropical diseases in general are close to my heart. I've been working on NTDs for many years, and so for me, good evening again to you all. 20 years ago, our Southeast Asia Regional Kala-azar Elimination Initiative was launched. This, as you all know, is a disease that had cast long shadows over us and over the region. Bangladesh, India, and Nepal accounted for nearly 70% of the global burden. But it's been a huge success story. 20 years later, we can proudly say that the burden has been reduced by 98%. In 2023, Bangladesh was validated as the first country in the world to eliminate Kala-azar as a public health problem. India and Nepal also achieved elimination targets by the end of 2023 and 2024, respectively. For us, this is a success story because it's a success story in terms of national leadership and regional partnerships. It's the result of the joint commitment of Bangladesh, India, and Nepal, but it's also been, of course, supported by WHO, multiple donors, research institutions, and perhaps most importantly, besides the countries, the frontline implementation partners. So there's no better better testament, I would say, to partnership, and no better testament to what we can accomplish together. So, with that, Suman, without further ado, let me hand back, and I look forward to hearing from all of you. I'll have to see off the Director General at some point soon. So I'm here to listen in a bit and may leave at some point and to say goodbye to Dr. Tedros. Back to you.
Thank you very much, Dr. Katharina. I think we are very honored and inspired by you coming, and your presence itself is a great thing for us. So as you said, this event has been hosted by the government of India and the government of Nepal. And we also have our partners, the Gates Foundation, DNDI, and of course CRO, who have been partnering with all of you all to make this event possible. Now, I would like to invite our leadership of our host countries, Ms. Hekali Zimo-Mimi, the Additional Secretary at the Ministry of Health and Family Welfare of Government of India, for opening remarks, please.
A very good evening, Excellencies, distinguished delegates, colleagues, and partners. I warmly welcome you all to celebrate the 20 years of regional Kala-azar elimination, commitment and innovation towards a healthier Southeast Asia. It is an honor to stand here and to address this important side event, which is co-hosted by India, Nepal, and Bangladesh. In 2005, India, Nepal, and Bangladesh signed a memorandum of understanding to facilitate the launch of the Regional Kala-azar Elimination Initiative. Since then, our collective commitment has driven historic progress. Bangladesh, as was mentioned by Dr. Katerina, was the first country to be validated to eliminate Kala-azar as a public health problem in 2023, and this was followed, of course, by India and Nepal in achieving the elimination targets by the end of 2023 and 2024, respectively. These milestones exemplify that when all partners in the region come together with solidarity, cross-border coordination, and unwavering political will, even the most challenging goals become achievable under evidence-based strategies. When a vision is powered by shared commitment, its success is inevitable. Excellencies, Kala-azar was one of the most serious public health challenges in India. It disproportionately affected the poorest communities. Despite this, India has made historic strides by achieving elimination threshold of less than 1 case per 10,000 population at the block level in 2023, thereby reaching the target well ahead of the WHO global goal of 2030. The reported cases declined by 95%, dropping from 9,241 in 2014 to 508 in 2024, while the case fatality rate remained consistently below 1%. The innovations that underpinned India's success include rapid diagnostic tests, an introduction of single-day, single-dose liposomal amphotericin B lamp, which replaced lengthy therapies and improved patient compliance. Locally developed solutions like the Gerard plaster reduce sandfly density and transmission risk. Further, community-driven initiatives like the Ratri Chaupal, which are the night meetings held in our rural areas, promoted awareness and care seeking. In addition, welfare measures such as the wage loss incentives and nutritional support reduce economic burden of treatment. The engagement of medical colleges also strengthened surveillance and service delivery, while digital platforms such as the Integrated Health Information Platform, the IHIP, which of course WHO assisted us in developing, enabled real-time reporting. Strong political commitment through regular ministerial reviews, and we had the Honorable Prime Minister's advocacy through Man Ki Baat, which those of you from our country would know is a program which the Honorable Prime Minister has instituted. It's about talking from the heart, and the disease was also focused on during his sessions, which was telecasted on the national radio. And this actually helps raise visibility, awareness, and focused efforts on the program. Our journey, however, is not without challenges. Post-Kala-azar dermal leishmaniasis, PKDL, the disease reservoir, requires stronger surveillance, treatment adherence, and research. Sustaining diagnostic capacity and vector control quality in a low-burden setting is resource-intensive, as we all know. Broader social determinants such as poverty, housing, sanitation, and climate change continue to shape the disease transmission. At the same time, India's experience opens opportunities to integrate Kala-azar intervention with other disease elimination programs, strengthening efficiency and long-term sustainability through a health systems approach. India's leadership has been pivotal in advancing the regional elimination agenda in the Southeast Asia region. In 2014, India contributed 30% of global cases, but by 2023, its share declined to around 4%. In a sense, India's Kala-azar elimination journey is a regional model of innovation, community participation, and political commitment. Cross-border meetings are regularly held, and notification of cases is done by India through WHO to the country of origin. India can further contribute by sharing best practices in community engagement, innovative vector control, and digital surveillance. Cross-border collaboration with the Southeast Asia region countries on notification of cases and addressing PKDL resurgence will be vital in sustaining elimination and moving towards a Kala-azar-free Southeast Asia. In conclusion, the journey of elimination of Kala-azar from the region should stand as a remarkable public health milestone as we collectively resolve to serve our communities, however remote or marginalized. Thank you.
Thank you very much, Madam. I think you really put the ball rolling for us this evening in trying to share what has been the experiences and initiatives taken by India and the region for this success story. And today, actually, we are not here only to celebrate the 20 years, but we want to learn from what we have done in Kala-azar, the blueprint which we have developed for one disease, and see how we can combine this or use it for other disease, communicable disease, which are relevant and diseases of poverty in our region. Thank you so much, Madam, for this. Now, I would like to invite His Excellency Dr. Purna Bahadur Nepali, Ambassador of Nepal to the Democratic Socialist Ambassador of Nepal to the Democratic Socialist Republic of Sri Lanka for his opening address, sir.
Thank you so much, Dr. Suman, for nice moderations and entering to the topic. That is from 20 years of journey of regional Kala-azar eliminations, commitments and innovations towards a healthier Southeast Asia to the multi-disease eliminations. Topic itself remind us the very serious, devoted and committed work. For a long time, I was in development sector as a development practitioners, researchers, for the short time, more than 5 years in academia. And topic itself is a very interesting for me, for my professional point of view. And the innovation and commitment itself, it reminds me that a randomized controlled trial that Abhijit Banerjee, the Nobel laureates who got it, and randomized controlled trial itself is not new for the public health professionals, scientists and academicians, but definitely it is a new for the economists, for the social scientists. The different tools and techniques that is being adopted in public health itself is a very serious and innovative. And that's why it's very important areas of interest. And my responsibility is to enter into the subject area. That's why directly I would like to enter into the subject area. And I would like to begin some of the things that I am supposed to deliver. And Excellencies, distinguished delegates and colleagues, it is a privilege for me on behalf of Government of Nepal to join you today in celebrating the 2 decades of regional Kala-azar eliminations initiatives. And these milestones remind us of how far we have come and the collective efforts to achieve the substantial regional outcomes. For long times, we have been spending our time very serious and devoted to dedicated works. And public health professionals, many medical doctors are very much passionate. As the results, they have been able to eliminate. It's very serious work. And since many decades, Kala-azar was among the most serious public health problem in our regions. with the South Asia carrying nearly the 70% of the global burden. Since 2005, countries in the regions have made historic strides under the WHO leaderships, guided by the regional technical advisory groups and supported by donors and partners to strengthen the capacity for case detections, diagnostic, treatments, vector control, and integrations within health systems. As a result, Bangladesh was validated by WHO 2023 as the first country to eliminate the Kala-azar as a public health problem, and followed by India and Nepal, achieving the eliminations threshold in 2023 and 2024 respectively. And we are very much proud of having being a third country for this elimination. This success is rooted in strong political commitments and sustained sources and cross-border collaborations and access to the essential diagnostic and the medicines. As we move forward and sustaining eliminations in low incidence setting remains challenging, the region must maintain the vigilant surveillance of full diagnostic and treatment services and ensure uninterrupted supply of diagnostic and medicines and address cross-border transmissions issues. Moreover, the Kala-azar elimination experience highlights the need for multi-disease elimination approach, ensuring the equitable access to high-quality public health interventions, healthcare services. Such initiatives will not only optimize the resources, but also strengthen the health systems and accelerate the progress towards the broader eliminations goals in the regions. And Excellencies, all ladies and gentlemen, and Kala-azar elimination shows the political will, regional solidarity, and community engagements can achieve. It's the kind of the multi-disease eliminations, also the multidisciplinary approach. Since today morning, we have been discussing all different approaches that goes beyond the technical issues. It also tries to capture the political wills. And Nepal remains fully committed to sustaining these gains, to contributing the broader agenda of multi-disease eliminations in Southeast Asia regions. And today, we all are gathered here to share experience of our Kala-azar eliminations journey, discuss the lesson learned, the way forward, not only for accelerating and sustaining the Kala-azar eliminations, for also for translating the success story to elimination of other diseases too. And just as we are discussing for other disease eliminations, and at the beginning, what I said, also I am trying to link whatever the different things and different approaches, tools and techniques that public health professionals, scientists, and academicians are adopting. And this is a time. The way Abhijit Banerjee, Nobel laureate, has demonstrated the randomized controlled trial that has been very successful, not new for public health professionals, but definitely it is quite new for the economists. But Abhijit Banerjee has rightly adopted and successful in demonstrating the very evidence-based solutions in different socioeconomic and different kinds of problems, and it is also the right time for all different disciplines to borrow and to apply, to demonstrate all different tools and techniques in our own field. And that's why I'd like to appreciate and acknowledge the contributions made by the public health professionals. And considering all these different things, and I would like to mention, we look forward to productive panel discussions with you all Thank you so much.
Thank you, Your Excellency. I must mention some of the things you said: regional partnerships, scientific innovation, and the unwavering collaborations and commitments. Thank you. So moving ahead, we will want to take you through this journey by a 5-minute video which we have created. So this is just to give you a glimpse of some of the efforts that have gone into making this success story. So over to you, if you could start showing the film, please.
For many decades, visceral leishmaniasis, also known as Kala-azar, cast a long, deadly shadow over South Asia. It spread silently through the bite of a tiny female sandfly, turning an invisible sting into a battle for life itself. Tens of thousands fell ill every year. The poorest and most vulnerable were hardest hit.
Every year, from 15,000 to 90,000 cases of visceral leishmaniasis or Kala-azar were reported.
During that time, Bangladesh, India, and Nepal had 80% of the Kala-azar of the world.
In 2005, Bangladesh, India, and Nepal signed a historic memorandum of understanding. They also developed the regional strategy for Kala-azar elimination in South Asia.
Over the last 20 years, a remarkable transformation has unfolded.
So those who have seen the poverty in Bihar or Jharkhand, they would know that how poor these patients are. I think WHO and the government of India and including academia has done a great job in reversing this trend and bringing down this disease from a mountainous height of say several 100,000 patients to 300 patients in 2024.
So Bangladesh, we also started the elimination program to alleviate the poverty through addressing these dreadful diseases, along with purchasing of diagnostic medicines and also insecticides for controlling the vector.
Nepal reduced Kala-azar cases by more than 90% in the period of 2005 to 2015. To sustaining our achievement on Kala-azar elimination process, we have strengthened our surveillance system and 3-year follow-up cases by increasing regular financing from government and partners, enhancing entomological capacity in the high-risk areas, and also enhancing cross-border collaboration.
The journey against Kala-azar has been defined by scientific breakthroughs. The creation of rapid, field-friendly diagnostics, simpler and more effective treatments, and stronger vector control strategies.
I think this is one of the very rare examples where academia has provided tools for elimination of a disease like Kala-azar in Indian subcontinent.
Backed by WHO TDR and DNDi, scientists across the region introduced breakthrough tools that changed the course of this fight. Miltefosine, the first oral drug for Kala-azar, simple, effective, and accessible. Ambisome, a single-dose, short-course treatment that proved life-saving. And the RK39 rapid test, fast, field-friendly, and revolutionary, bringing diagnosis to the doorstep of every village. Together, they turned the tide against a disease once thought unstoppable.
Integrating the innovations for diagnosis and treatment as a point-of-care test and treatments within the primary health care was critically important to accelerate the program and also to sustain the program as we went along.
WHO, TDR, and WHO itself provided so much support in elimination of Kala-azar in Bangladesh. Along with that, other development partners like UK and Melinda Gates Foundation and DNDi, JICA, they also provided support in achieving our elimination.
After decades of determination, South Asia stands at the threshold of a remarkable public health achievement. In 2023, Bangladesh became the first country in the world to eliminate Kala-azar as a public health problem. India and Nepal are now at the cusp of achieving the same milestone. To ensure this progress continues, countries are already planning ahead. Post-Kala-azar dermal leishmaniasis, or PKDL, can appear after recovery and silently spread the parasite, threatening elimination. Tackling it is key to sustaining progress achieved.
Today, the concept of multi-disease elimination builds on these factors which we have used for Kala-azar elimination, where we have a patient-centered approach to the primary health care, and we also break down the silos and also address the social determinants to health.
Southeast Asia's journey against Kala-azar is a story of political commitment, regional collaboration, and community engagement. It shows that when leadership, communities, and science come together, elimination is possible, even in the toughest settings. In this journey, our region has created a blueprint for people-centered, multi-disease elimination that can inspire the world.
Thank you. Can we put the slide, please? Thank you very much. This was really a great experience and we try to bring this in 5 minutes, which is sometimes very challenging and difficult. But then we also have a legend with us today, Professor N.K. Ganguly. Many of you may know him, but some of you who do not know him, I would like to just give you a brief introduction. Professor Ganguly is currently the chairperson of the Department of Biotechnology and Research at Sri Gangaram Hospital. He was the Director General of Indian Council of Medical Research from 1998 to 2007. And this was the time when these researches, this Kala-azar initiative, and also the collaborations between the countries was initiated. So Sir has a great understanding how this all came through. Under his visionary leadership, ICMR emerged as a global powerhouse in infectious disease research, particularly advancing the diseases of the poor, LF, VL, and other entities. He has also been advising the ministry, and he has been advisor to 13 union ministers to shape national health policy in the Indian government. And he has also received one of the highest national civilian awards, the Padma Bhushan, for his exceptional contribution to the science and medicine. So, sir, I know these are very few words to introduce yourself, but we will be very happy to hear from you on the story of how this started and how you were able to get the different countries and the different researchers to take this story along. Over to you, sir.
Thank you, Dr. Suman, Dr. Aya, Government of India, Nepal, and Bangladesh, as well as the Gates Foundation, DNDi, and all the partners to provide me this opportunity here. Actually, I had the ringside chairing about more than the RTAG for almost more than a decade, and also the ACHR for more than a decade, and the NDVPC Technical Committee and ICMR Committee. So really I saw all of this happening in front of my eyes. So if we really see the graph this side, every 4 years we had a surge, and I never imagined that we could ever control this or eliminate this. So if you see this graph, this is the same story in Nepal, same story in Bangladesh. It started dropping. The challenge was actually the PKDL, as it was identified, human reservoir vector, which was very, very difficult to control. The major players were shown over there, but I will like to acknowledge Dr. C.P. Thakur, he was the health minister during my time, and it really made a big difference. And Dr. T.K. Jha, but others were shown over here. And in Bangladesh, Benazir was also shown there. And in Nepal, Dr. Garib Das Thakur and A.V. Joshi. And in Sri Lanka, Dr. Nadira is sitting here. All of them were the real major pair. And the partnership which emerged was really very strong. One of the things which I want to mention, that this region created huge innovation. All the drugs, right from the UN Brahmachari's tibaglucamine to Ambisome, which was discovered by Dr. B.K. Bachawat in India, was all were, and miltefosine story, which was the game changer, all were developed or validated in the Indian subcontinent. So this was a huge thing which happened. The partnerships also developed the pressure pump for the spraying and studying the habitat of the phlebotomus, as well as there were partnerships which actually reached out the people at the lowest rung of the economy, and that was one of the challenge, and we also found solution for PKDL. So all of these innovations at every level, including the syndromic disease identification and the donors, all of these made a huge difference. So this is one of the questions which was actually Bhupender perhaps was to ask me this question, but this is something which is most important, and I will go with it with the next slide. So this was the disease of poverty, and WHO actually created an arm for disease of poverty. So Musahars, who moved between Bangladesh, Nepal, and India, were the most affected. They neither had a house, nor a telephone, nor a newspaper, nothing. And so these guys never knew where to go. So one of the program what they did through the partners, so partners were very, very important. Some of them we have named, they reached the poor. And they used to become pauper, and they went below poverty line. So this was one of the major things which was done. The social stigma and isolation, you could see the face, that was like leprosy, and it was dealt with very, very effectively. So they were no longer pariahs. The impact on the children were the most affected. And they couldn't go to school, they were stunted, their development didn't occur. So the priority for children also made a big difference. Then equity and ethical imperatives were very, very important, because these were costly drugs, these were costly treatment, and you had to really reach to the poorest of poor. So when the miltefosine happened, before that, Dr. C.P. Thakur and others who were doing T.K. Jha, Shamsundar, who were doing these trials, they knew what was the really big problem. So when miltefosine came, we could reach to the doorstep. And at that time, C.P. Thakur created this particular thing. Within 2 to 3 years, this drug was put through the regulation to the people. And this again went to the policy, because he was a minister at that time, very committed, so it went to the policy. He conceived that let us work together, and this agreement was done. And when Bhutan was affected, then this agreement was enlarged to 5 countries. Next, please. There's my last slide, last question, that how did the tripartite agreement transform the Kala-azar? Actually, this was something which was really very, very important. So this RTAG, which was set up for the Kala-azar, this really made a very, very important contribution. Actually, here, the main guidance, the active surveillance system which went on, the introduction of the diagnostics and availability of diagnostics, all the elimination strategies and the decisions were taken together. and they were grounded in the regional evidences. So evidence-based decisions were made through the RTAC, and everyone agreed, including the ministries in these countries. The joint training and cross-learning initiative, like we learned that the patients in Nepal sometimes came and got treated in Bihar, and many times because Nepalese system was much more efficient, the borderline of Bihar people went to Nepal and got treated there. And we learned how this particular thing is transmitted and how the moving population could be dealt with. So this was very important. And cross-border surveillance and resource sharing was again, so drugs were shared. One of the policies which was adopted by India, Bangladesh and Nepal, they shut the DDT use, and India followed it later on. But this experience in those countries actually created this system. And these drugs and the diagnostics and their use and the clinical trial, Dr. Nepali told about the RCTs, all of these then spread to these countries, and these could be implemented. My last point will be that how could we, like in filariasis Medsicant donation, the amphotericin B donation was done through the Gilead. And it was provided seamlessly, and in the same way miltefosine was made available, although there were ups and downs, but this was made available. So all these were important, and I will conclude by saying that we need to be vigilant, we need to maintain these partnerships, we need to maintain this coalition, we need to maintain the active surveillance and availability of the goods and reaching out to these poorest of poor. Otherwise, it might come back again. Thank you.
Thank you very much, sir, for sharing those experiences which are so valuable. In fact, it is like to say that that time, if you remember, there were different cogwheels, and all of them were of different sizes, but they were moving in tandem. That's why they were able to generate the evidence. The evidence was translated to recommendations by the ITAC and then adopted by the partners. And also the donors facilitated the availability of these new tools. And then there was partners like PATH and others who were able to operationalize in the field. So it was really a perfect way to work, and each had their strengths in the different areas. So thank you, sir, for sharing that. So I know we are slightly behind time, but we'll try to make up. We will then have a panel discussion. Now this panel, the first panel discussion is on the success factors and lessons learned and the way forward to accelerate and sustain elimination of Kala-azar in Southeast Asia. So we have representations from India, Bangladesh, and Nepal, the three countries who initially signed the MOU. And then we have partners like DNDI who would be joining the first session. So if without any delay, I know Nepal is joined to us virtually. So I hope he's connected. So my way would be that I will start with one question each, and we'll go through the rounds, and then we'll see how we progress, and then we can come back for the second question. Try to keep your answers short and brief so that we can have more discussions. So I would like to first introduce you to the panelists. So from Bangladesh, we have Professor Khair Ahmed Chowdhury, who is the Additional Director General, Administration Director General of Services, Ministry of Health and Family Welfare, Government of Bangladesh. So, sir, for you, the question is, Bangladesh eliminated Kala-azar, as we all heard, in 2023. What were the key enabling factors that helped you to achieve and accelerate to this elimination? And also, to sustain this success, what are the must-do steps that needs to be in place? Over to you, sir.
Honorable delegates, respected audience, very good evening to you all. So Bangladesh's success is due to the strong leadership, commitment of health workers, volunteers working together with WHO and partners to ensure the effective early diagnosis, treatment, surveillance, complete case management and vector control, as well as sustained health system capacity for successful post-mobilization surveillance and response. The strong political commitment is one of the important factors which ensured Kala-azar elimination remained a national priority. This translated into sustained funding and policy support. The availability of diagnostics, tools, and drugs which were provided free of cost. The treatment protocols were revolutionized with the introduction of single-dose amphotericin B, vector control, high coverage of indoor residual spraying. The progress toward public health elimination of Kala-azar was expedited by the strengthening of active and passive surveillance, case-based reporting via the District Health Information Software introduced in 2015, allowed for real-time data collection and rapid response. A dedicated workforce ensured the smooth implementation and monitoring of interventions. Trained personnel from central to peripheral level played a pivotal role in maintaining momentum and accountability. Finally, the collaboration with development partners such as WHO, Gilead Science, and the Bill and Melinda Gates Foundation provided technical expertise, resources, and global visibility. Together, these technical and strategic factors formed a powerful framework that not only eliminated Kala-azar as a public health problem in Bangladesh, but also set a global precedent for tackling other neglected tropical disease. So to sustain this success, what are the must-do steps that needs to be in place? It demands a continued vigilance and strategic action to prevent resurgence. To preserve this hard-won success, a comprehensive set of measures must be maintained and strengthened. First and foremost, the implementation of all key recommendations made by the independent validation team is critical. These expert insights provide a roadmap for sustaining elimination and addressing gaps. Equally vital is a continuous capacity building of healthcare providers, a reliable and uninterrupted supply of diagnostic and medicines, to expedite interruption of the disease transmission, surveillance systems must be upheld with case-based intervention. In the post-elimination era, Bangladesh must embrace integrated approach such as PKDL is important, as we know that it's a very important resource in the transmission. So early detection and treatment of PKDL is one of the important. Establishing cross-border surveillance by sharing the information between the India and Nepal. Finally, securing long-term funding is essential. Adequate resource allocation from the government combined with continued donor support will ensure uninterrupted supply chains and the strengthening of surveillance and response systems.
Thank you very much, Professor. I think you have really covered, the enabling factors that led Bangladesh, and also you have also clearly identified what you need to do to sustain what you have gained. So moving forward, I would like to now introduce to you our panelist from India is Mr. Pushpendra Rajput, who is a Joint Secretary at Vector-borne Diseases in the Ministry of Health and Family Welfare, the Government of India. So the question to you is, as India stands on the verge of Kala-azar elimination, what were the most significant challenges faced during the last mile and how are they being managed?
Thank you very much. Good evening, distinguished delegates, colleagues and partners. So regarding most significant challenges we faced during last mile, so as India reached the WHO elimination target of less than 1 case per 10,000 population in 633 endemic blocks by 2023, the final phase of Kala-azar elimination presented unique last mile challenges. One of the key threats was complacency among health workers and communities. Persistent and silent villages may continue to harbor undetected cases, acting as hidden reservoirs of infection. Management of post-Kala-azar dermal leishmaniasis, PKDL, and relapse cases remains critical, as these individuals can reintroduce parasites into the transmission cycle if not promptly treated. Migration and internal mobility increase the likelihood of cases emerging in non-endemic areas where health systems may not be prepared for timely diagnosis. Another challenge is ensuring continuous monitoring of vector resistance to insecticides, which is again vital to sustaining the effectiveness of indoor residual spray. Sustaining cross-border information sharing on cases is also necessary given the porous nature of borders in the region. Above all, maintaining political and financial commitment during a low incidence phase is difficult but essential to ensure the gains of elimination are not reversed. Further, to sustain Kala-azar elimination, the highest level of priority is being accorded to ongoing monitoring and periodic reviews for continuous sensitization of stakeholders. Intensive surveillance is being maintained to ensure timely case detection and prevent any reemergence of transmission. In parallel, efforts are also being directed towards comprehensive dossier preparation and documentation to validate and sustain the elimination achievements. Thank you very much.
Thank you very much, Mr. Rajput. Now, moving on to Nepal, our panelist is joined online, and thank you for opening your video. So, Dr. Gokarna Dahal, he's the Section Chief of Vector-borne Disease Entity Section at the Epidemiology and Disease Control Division at Ministry of Health, Nepal. So, the question to you, Dr. Dahal, is Nepal's once achieved the elimination targets earlier in the Tarai, but the endemic regions then extended to the hilly districts. Since the last 2 years, Nepal has invigorated its efforts to re-achieve this elimination targets again. What were the primary factors at the program, systems or community level that contributed to this recent achievements of the elimination target? Over to you, Dr. Dahal.
Thank you. Namaste and warm greetings from Nepal. Thank you, Dr. Suman, for this opportunity. So it's my pleasure to share Nepal's remarkable re-achievement in the Kala-azar elimination target. It was made possible in 2024 and even in 2025 till now through renewed political commitment of the country, strong surveillance, and the decentralized service delivery. With the changing disease epidemiology and paradigm shift from eastern dry to western hilly part of the country, the government of Nepal revitalized its program with the focus strategy approaches, programmatic, system strengthening, and the community level. At the programmatic level, we strengthen our case-based surveillance with the verification and GIS mapping of each and every cases, reported cases, and the active case detection and the follow-up of the patient for up to the 3 years, which helped us to identify the post-Kala-azar dermal leishmaniasis and relapse cases early. Free diagnostic test services and the test and the treatment with the liposomal amphotericin B were ensured nationwide. In addition to this, the country support the transportation supports the patients and other needed laboratory investigation if needed. The hospital, they provide the free of cost to the patient. So all the national guideline, document, and SOPs, they provided us a strong technical foundation. If we talk about the system level, entomology and vector control capacity were expanded to all 7 provinces. We are in the federal government's structure now. So we do the integrated vector surveillance and the indoor residual spraying in the high-risk areas. So training to the clinician, paramedics, and entomology, which improved us the diagnostic and treatment quality. At the community level, the awareness campaign during the active case detection, which improved the early health-seeking behaviors of the community people. And recently, the decentralized governance, and which increased the provincial and the municipal investment in the Kala-azar elimination program, which gives a local ownership and accountability for the country. So during this journey, the support from the WHO and the Bill Gates and Melinda Gates Foundation, and recently from the DNDI, which has been instrumental in enhancing Nepal's technical and programmatic capacities, ensuring high quality diagnosis, treatment, surveillance part in the Kala-azar elimination process. So our experience that we learned from this programmatic experience is political ownership, community participation, and the partnership with the development partner are essential to sustain the Kala-azar elimination in the country. So during these 20 years of journey, the cases are significantly decreased. We are in the last verge of elimination. Thank you.
Thank you very much, Dr. Dahal, for sharing those experiences. So as we have heard from these 3 countries who have been very successful in achieving or moving towards the target, now we move on to Drugs for Neglected Disease Initiative, who has been a key partner in developing these new treatments and also trying to develop evidence at the field level. So we have with us Dr. Shiraj Raja, the Senior Clinical Project Manager of DNDI. And Shiraj, the question to you is, translating evidence, including innovations, into policy change can be time-consuming and also very challenging. Can you share how DNDI has achieved in the Kala-azar program? Can you share how DNDI experience in achieving this translation for Kala-azar program in the subcontinent? Thank you.
Thank you for providing this opportunity. So what I think really worked is the strong partnership between the researchers, national programs, WHO, and the implementing partners that were working from the start of the program. And this strong collaboration brings together the new treatments into the policy. A good example is the adaptation of the single-dose liposomal amphotericin B and the move from the hospital care-based care into the primary healthcare system. So in a way, the government also took initiatives of taking care of these evidences into the policy. WHO regional committee also helped to make sure that these evidences should not stay on the paper but come into the policy. So these are all the partners that take care of the innovations that quickly came into the policy. While we have seen a lot of strides, we have seen few instances also where the policy change has been slow. So we are working towards with the WHO and other partners to bring these policies into seamless process. Thank you.
Thank you. Since I was in DNDI, maybe I can share my experience. So DNDI is, they are developing new treatments, and it can be repurposing of older drugs, but also new molecules. And one of the first things they do is developing a target product profile, and that is based on the needs of the people. So during this development, you don't only have the scientists sitting in that room, you have clinicians who are treating the patients, and sometimes even the patient communities their voices are being heard, that what do they like? Do they like an injection? Do they like a tablet? Do they want to take it for 1 month or 7 days? And then the scientists then are advised to develop a product which is suitable for the population who is going to use it. Second thing is, they always involve all the stakeholders, and in this case, for policy change, you have to get the program on board right from the beginning and not take the product to the program, but make the program involved in the development of the whole process. And I think it's been a successful example, and they have developed, I think now, around 14 new treatments in Africa and Asia and other places. So I think this was a very interesting model which they used to develop new treatments. It's not a pharma company, but they have been able to be as efficient and successful for neglected disease. Thank you. So we had a very comprehensive answers from our panelists. Because of the interest of time, I would like to move on. And apologies, I know you have prepared for 2 questions, but let me just take forward. And I would like to invite, because this is a very interesting component, because what we said in the beginning is we want to learn the lessons from Kala-azar elimination and to see how we can accelerate for other eliminated disease. You know, we don't have a lot of time. We have the SDG 3.3 targets for eliminating TB, malaria, TB, HIV, but also a neglected tropical disease by 2030. But we see how can we do that in a more efficient way when now we are seeing less resources being made available. So over to you.
Thank you, Dr. Suman. So my name is, good evening, everyone. My name is Ai Yajima. I'm the regional advisor on neglected tropical disease in WHO CRO. So today I'm just sharing on behalf of Dr. Suman because he's talking throughout the event. So on behalf of Dr. Suman, I'm going to share a draft concept of the strategic framework for accelerating multi-disease elimination. So the WHO Southeast Asia region has made outstanding progress in disease elimination over the past decades. As you can see in this timeline, achieving major milestones including polio, measles, the malaria, lymphatic filariasis, Kala-azar, trachoma, and etc. However, as Dr. Suman mentioned, despite this hard-won success, our progress towards SDG 3 targets, and especially the elimination of all remaining target diseases, is still lagging behind. And to accelerate our progress in the next 5 years, and to ensure achievement of the critical low-hanging fruits in terms of the disease elimination, we recognize that we need to transform our approach. So disease elimination requires the delivery of public health intervention or services for all in need in communities. And depending on the disease, it might be a combination of different surveillance or individual case management, immunization, mass drug administration, vector control, etc. And to facilitate delivery of evidence-based public health intervention and services, each disease-specific program adapts a global and regional guidance to the country context, develop a national strategic plan, SOP, and various tools, and build capacity of health workforce across the region, across the country for implementation of the relevant intervention. But it is often that multiple programs deliver the similar public intervention or services to the community separately. For instance, health workforce conducting or implementing active case detection might reach out to the community one day for leprosy, another day for Kala-azar, and the next day for TB. Or the same similar entomological activity, surveillance or vector control, might be implemented separately by malaria program, LF program, or Kala-azar program. Or vaccine supply chain for rabies program is often established in parallel with one of the immunization program. And this may often cause duplicated use of resources to the health system and also inconvenience from the community point of view. But also, secondly, despite all disease-specific efforts, disease elimination efforts continue to face challenges in delivery of intervention. And this is often due to the existing health system gaps. This might be a lack of sustainable financing or lack of health workforce capacity itself in case of case management or laboratory or vector control or suboptimal health information system or supply chain system. A lack of entomologists, for example, in most parts of this region is a very good example. And the challenge also includes a social and environmental determinants of health, such as poor housing or lack of basic community infrastructure, or low health literacy in community in general, or even gender or cultural barrier. And often addressing these challenges are not the scope or expertise of the disease elimination program. So people-centered multi-disease elimination initiative that we are advocating is to accelerate, aiming to accelerate elimination of multiple diseases by breaking silos and addressing delivery of intervention and services, health system strengthening, and social and environmental determinants of health through integrated, sustainable, and holistic approach. Our goal remains achieving each of the targeted disease elimination in respective country. But first, we promote integration or coordination of intervention services between program or with primary health care, wherever it leads to synergy, efficiency, or cost saving, while maintaining clear disease-specific targets. And second, communicable disease program should, The communicable disease program should work more closely with a program or departments or donors or partners working on the health system strengthening to bolster health workforce supplies, surveillance, financing capacity to support delivery of multi-disease elimination intervention and its universal coverage. And third, and similarly, we need to better coordinate also and collaborate across sectors such as WASH, housing, education, or social welfare to confront the fundamental factors driving disease transmission and inequalities in target areas, again, in a more integrated and coordinated manner. And operationalizing this require whole-of-government approach or shared accountability and also intersectoral and evidence-based monitoring. And those whole-of-government collaboration will be driven by maintaining disease-specific elimination goals and strategies so that progress is monitored towards a measurable disease elimination target. But saying this is easy, but operationalizing this won't be very easy. For example, we need we will continue to have aligning strategies and intervention resource allocation across different disease programs while maintaining clear disease-specific targets can be complex and may face resistance. In fact, there is also a fear or the risk that integration might dilute disease-specific technical expertise and focus, potentially weakening specialist attention, targeted intervention, accountability for elimination goals in individual diseases. And also, so here we need a research and innovation with support of partners to find the most feasible and operational strategies for integration and PHC-centered approach. Yet, often there is also a disease-specific donor requirement that might restrict integration of other diseases and reinforce the existence of parallel or siloed program for each disease area. So we need also a flexibility from donors for enabling more holistic approach. So to discuss the way forward, WHO CRO plans to convene a member states consultation in 2026 to advance conceptualization of this multi-disease elimination and also discuss the way forward for its operationalization in the region. And we wish to hear more perspective from selected countries and partners again in the next panel discussion. Thank you very much.
Thank you very much, Aya. I think it was a very clear presentation of what we want to do, but how to do it is the next question, you know. And so we thought that it may be interesting to hear from some countries who have already moved forward in some of the areas. So in the next panel discussion, it's a regional multi-disease elimination initiative, the opportunity, challenges, and the way forward. So we have Bhutan, Sri Lanka, Gates Foundation, and PATH. So we would like to invite the panelists. From Bhutan, we have Dr. Hari Prasad Pokhrel, the Deputy Chief Program Officer, Nutrition Program. From Sri Lanka, we have Dr. Asela Gunawardena, the Director General of Health Service, Ministry of Health, Sri Lanka. from Gates Foundation, our friend Dr. Bhupender Tripathi has joined us online. He really wanted to be here with us, but due to some circumstances, he was not able to join. He's the Deputy Director of Infectious Disease and Vaccine at the Gates Foundation in Delhi. And Dr. Neeraj Jain, the Country Director of PATH India. I don't know, Neeraj, I think your role has expanded beyond India, right? Sorry. Okay, so let's move forward because we would like to finish on time because I know it's getting pretty late after a long day starting at 9. So my first question is to our panelists from Bhutan. Bhutan has success in indigenous malaria cases and is on track for WHO malaria-free certification, and we are really looking forward to that. How can the malaria elimination capacity, such as robust surveillance, rapid response, vector control, and community engagement, be leveraged to tackle Kala-azar and support multi-disease elimination goals? Over to you, please.
Thank you, Dr. Suman. Excellencies, distinguished delegates, ladies and gentlemen, I will start by sharing Bhutan's progress in eliminating malaria, a milestone that reflects years of dedication, innovation, and partnership. For the past three consecutive years, Bhutan has reported 0 indigenous malaria cases. The few cases detected in the recent years were all imported, and the country now meets the WHO criteria for malaria elimination. We look forward to achieving malaria-free certification in 2026. But more importantly, the systems and capacities built through malaria elimination, our robust surveillance, rapid response teams, vector control measures, and strong community engagement are now being leveraged to address other vector-borne diseases, particularly Kala-azar. In Bhutan, Kala-azar elimination follows a case-based approach with every confirmed case investigated, treated, and followed up for 3 years. Through indoor residual spraying, active case finding, and close monitoring for relapse and post-Kala-azar dermal leishmaniasis, we have maintained an incidence of less than one case per 10,000 populations in the endemic districts. We are now integrating our malaria and Kala-azar efforts under the broader vision of multi-disease elimination. This includes expanding integrated vector management, targeting both sandflies and mosquitoes, building capacity for case management and surveillance, engaging communities and the private sector. For example, the private diagnostic centers now help screen migrant workers, while the private partners collaborate in distributing the insecticide-treated nets, ensuring that no one is left behind. Our experience has also shown that regional cooperation is essential. Bhutan continues to work closely with neighboring Indian districts through WHO-supported cross-border mechanisms and the Southeast Asia Regional Coordination Mechanism forums. These partnerships have been vital in synchronizing surveillance, sharing data, and coordinating response across the borders. Distinguished delegates, the success of malaria elimination has taught us that with strong political commitment, community participation, and regional solidarity, elimination is indeed achievable. Bhutan remains committed to sustaining these gains and applying the same integrated, collaborative approach to eliminate Kala-azar and other vector-borne diseases, contributing to the region's vision of healthier disease for healthier and disease-free South Asia. Thank you.
Thank you very much, Dr. Pokhrel. So I would like to now ask Dr. Gunawardena. So Sri Lanka has eliminated malaria since 2016 and also lymphatic filariasis. So, and also now the anti-malaria campaign is made responsible for leishmaniasis control. So what key strategies or capacities developed for malaria or LF could be further strengthened or repurposed to accelerate the control and elimination of leishmaniasis and support broader efforts towards multi-disease elimination in Sri Lanka?
Thank you for giving this opportunity and all the excellencies and all the delegates. Actually, Sri Lanka declared the malaria free in 2016, and as well as the lymphatic filariasis as a public health problem. The success story of malaria elimination is the strong public health surveillance system and community-based interventions and the intersectoral collaborations, and the most important thing is the dedicated health staff who work tirelessly for the decades to eliminate malaria. So the visceral leishmaniasis or the cutaneous leishmaniasis, the visceral leishmaniasis, we are getting very few cases in Sri Lanka, but we are having this cutaneous leishmaniasis. What we are doing is we are leveraging the existing capacity of anti-malaria campaign for the same purpose. And we made leishmaniasis as a notifiable disease and for the surveillance matter. And we do the public health, the field investigation through our existing public health staff. And the laboratory diagnosis, which we have already has for the anti-malaria campaign with the microscopist who do the slit skin smears on this suspected patient, and for the PCR for the confirmation. And as well as for the entomology side for the vectors, we have the entomology surveillance team who are already in place, and as well as the community engagement and health education is done by our public health staff who are PHMs, public health inspectors and all the other field staff. This is how we try to take the anti-malaria campaign, the existing workforce for the leishmaniasis control.
Thank you very much. Thank you. Moving forward, I'd like to now ask Dr. Bhupender. Gates Foundation's involvement and support has been one of the game changers in Kala-azar elimination in the region, and we have heard many of the speakers alluded to that earlier. From the Gates Foundation's perspective, what are the most impactful investments or partnerships that have advanced Kala-azar elimination in the region? And can you also tell us how these can be leveraged for multi-disease elimination? So there are two parts to this.
Thank you, Dr. Suman. Good evening, everyone. Greetings to all the dignitaries from the Gates Foundation. Let me start by thanking WHO for organizing this side event and congratulating the country officials and partners on celebrating Kala-azar elimination progress. I'm sure the subcontinent will achieve validation of Kala-azar elimination very soon. I'm glad this neglected tropical disease is reaching elimination level and so many families will be saved from this deadly disease. I'm also happy to see WHO leadership about leveraging Kala-azar elimination lessons for elimination of multiple diseases. Now, let me start by emphasizing 4 learnings from the Kala-azar efforts. First was about the strong commitment and leadership by the national governments and state governments, whether it is India, Nepal, or Bangladesh. That was the most important thing I would say for any disease elimination, and Kala-azar was no exception. In place of posting bureaucratic, political, technical experts, everybody was committed towards this goal. So that is the first and foremost. The second is about the role of WHO in providing timely guidance and feedback. So WHO headquarters, WHO CRO, and the country offices, I think that was an important role which you have played. Thanks to you. The third is about close collaboration with academic and research organizations, whether it is for innovation, whether it is for implementation of new tools or pilots. It also, not only one country, but multiple country stuff happened. We also invited people beyond Asia and they contributed a lot. So that was one more learning. And the fourth one was contribution from partner agencies. So whether it is DNDI, whether it is PATH, whether other organizations, I think they contributed, including pharma partners. Like companies came up, they gave drugs or diagnostics initially on donation. They are still continuing, a couple of them. And then how the community was sensitized and engaged. So I think these learnings we have from Kala-azar elimination. Now coming to the second part of the question, with a change in global disease and funding ecosystem, there is a dire need to start integrating and leveraging efforts. For this panel discussion, I'll share a couple of thoughts, and Aya has very rightly, mentioned in her presentation as well. So one is about micro planning. So ideally, what happens, when we classify populations, we can very well say that which is the subgroup population which is highly, at risk for communicable diseases, vector-borne diseases, or even non-communicable diseases. If we identify the problem, the same family may be having, poor sanitation, poor housing, poor efforts on other diseases. And these type of populations can be a proactive approach we can follow to figure out these where they are. The second is about the health workforce, as I also mentioned. Depending upon the geography and environment, we can select and identify diseases on which we want to train our health force. And that health force, whenever they go into the field, whether it is for surveillance or whether it is for action or any other active case searches, they can ask not for one disease, but for multiple diseases. One question which Aya raised very well was that there is an apprehension of losing knowledge of individual diseases. So on this, my suggestion is that, we have medical colleges and we have research institutions in all the countries. We can always identify individuals or group of individuals who can be allocated that specific expertise, technical knowledge, and they can be invited for all the updated, databases researches, and they can continue with that knowledge. But the larger program implementation people can be integrated very well. The next is about disease surveillance or surveys. Whether it is active case searches, whether it is searches using xenomonitoring efforts, wastewater surveillance, or some type of serological surveys. All these can be done with multiplexes, and there are opportunities where we can integrate. So not only one disease, but multiple diseases can be identified. The next is about the data system, especially the platforms. Instead of developing individual platforms for individual disease, if we can develop the platforms for multiple diseases and an option for adding more diseases if required, I think that will not only save time of health workers, but it will also help everybody in the chain. Having dashboards which can actually integrate will be also help. If you overlay the map of leprosy, Kala-azar, PKDL, malnutrition, and poor housing, we may have pockets. So having that dashboards availability. And one more important point on the data is that data should be shared within the respective departments. Sometimes what happens, we will be working on disease A, and we may not share the data for disease B, which is managed by a different division in the health ministry or any other division. That is very important. Then the supply chain, whether it is drugs or diagnostics, if you develop a supply chain system which is integrated when shipping the specific logistics in the field, we can leverage each other and ensure that minimal investments are made on that. Then community mobilization and sensitization. If you are educating the community, why not plan a whole calendar that we keep on advocating and educating in multiple diseases? Then we definitely need WHO leadership in anchoring these efforts to keep everyone connected and bring the teams back when teams start moving astray. So the role of WHO will be very important. And then finally, I think donors collaboration and integration is equally important. So I think from the Gates Foundation side, I would like to commit Gates Foundation's efforts. We will be very open for collaboration, co-funding, and investments, which should help not only for one diseases but for multiple diseases. With this, I want to thank WHO once again and all the experts sitting over there. Back to you, Dr. Subhan.
Thank you very much, Bhupendra. I think it was such a interesting but very informative and very collective answer you gave. And I think that captures a lot of things, which we were looking forward to. So I think this is also something, we need to take note of when we are planning the next step and to see how we prepare ourselves in these different areas. Now we have PATH, who has been a very important partner in the region, who has also developed, done innovations. They have done some epidemiological studies, trials. They have been involved in trials. And also they have been supporting the programs to implement many of these innovations and also monitor the success. So, Neeraj, as a technical partner, how has PATH supported countries in developing integrated deliveries platforms for vector-borne disease and in Kala-azar elimination? And what success can be built upon for multi-disease approaches?
Thank you. Thanks, Suman. Excellencies, ladies, gentlemen, thank you for giving us this opportunity. I'll be very quick. I think it's been a long day and I'm probably I'm getting the last word here. So very, very quickly. So PATH has been working in Bangladesh, India, Nepal and Sri Lanka with providing technical assistance for Kala-azar elimination, we've been very proud of that. But also we've been progressing on LF elimination. We've been working on acute encephalitis and most importantly, high-grade fever. That's the direction that we've been going. So thinking about integration as we are hearing, I think it's very important, the direction that we're going. Integrated workshops we believe will be required for multiple diseases. We are still operating in various silos. We've been doing a bit of that. We've been also looking at pharmacovigilance from a multi-disease elimination perspective. Outbreak investigation, again, trying to look at it beyond just one disease or the other. Integrated active case searching. This is, if you look at the state of Uttar Pradesh in India, there's some really interesting work happening there where integrated active surveillance is happening. Combined monitoring, of course, has been talked about quite a bit. Integrated data management and dashboarding. I think this is something which has had a huge impact, especially for the public health programs in multiple governments. Once they're able to start seeing data together, there is definitely that push to have higher impactful interventions. Since I don't think you're going to reach the second question, Suman, I'll take another minute to just respond to think about what we can do. I think I would really urge the WHO for a global regional guideline on integrated MDE. I think that's the way forward, and a guideline would really help all of us come together in terms of our thinking. We need political buy-in at the World Health Assembly level, so we're urging you to take that forward. Collective, merged, pooled hybrid funding models. That's going to be important, and also bring the private sector in if possible. That would be good. Convening cross-border. I think we do a bit of that, but maybe a little bit more would help. Integrated surveillance in the CRO region. So can we bring countries together and start looking at data more as a region? Alignment with national government and donor partners. I think that in some cases comes later, but maybe could start earlier. And finally, intersectoral coordination is going to be critical, and WHO has a big role to play there. So leaving you with some of those thoughts, very excited, very happy to work alongside you. Thank you.
Thank you very much, Neeraj. Thank you. I think you brought on a lot of important elements there, and we really will take note of that. So, ladies and gentlemen, I know we are coming towards the close, but people who are online, if you can stay on for the next 5 minutes, because we have this wonderful audience who has been with us since the last almost 2 hours. So we would like to know if you have any burning or any questions you would like to ask any of the panelists. I just think we can have maximum 2 questions. If any of you would like to have a question, ask a question, burning question which you wanted to ask. If not, of course, we can close. Or you can make or you want to make a comment or anything. You don't need to ask a question. Anybody?
Thank you everyone for giving me the opportunity. I am Ahmed Al Mansour from Bangladesh, as a your delegate from Bangladesh. The success of Kala-azar elimination in Southeast Asia clearly demonstrate the power of strong regional collaboration between countries like India, Bangladesh, Nepal. However, we entered the post-elimination phase and looking at multi-disease elimination strategies, how can government and partners create structural platform for youth-led cross-border initiative, particularly in research, digital health initiatives, and rapid response mechanism to build a resilient regional health security system? WHO officials.
WHO officials. So I know I'm a moderator, yeah, at this moment. So thank you. I think, young people like you should challenge us, question us. And in fact, if you can see that the presentation of Dr. Aya, it's trying to address many of those components which you are saying is can we integrate, how can we bring together. Now, I'll give you some examples which is already happening within WHO. So first, we need to understand what it's, sometimes you can make a policy or a program, but it has to be something which the countries have to own it and they have to be able to implement it. So that's why the countries come at the center, the programs come at the center. So what we have started doing is, because before we used to go and monitor, say, the malaria program, or the LF program, or the VL program. Now what we are doing now is, because there is some commonality in that they are all vector-borne diseases, and most of them are coming from the same epidemic or endemic foci. So we are going together with the malaria expert, the NTD expert, and even the surveillance experts and entomologists. So we go together and we try to work together to see what are the common synergies there. And then we try to bring that all together and discuss it with the program. So this has been happening. We have already done that in Nepal. We've done that in Bhutan. We've recently this year have done that in Sri Lanka. And we have learned a lot. So that's why she has proposed that next year we would like to have a more informative, to getting all the partners and even the programs together to see how we can develop a strategy for the region to see and how we can take this forward. So it's going to be a long journey, but then we have to take the initial steps, and this is what we are doing. Similarly, this year, we are going to organize a surveillance framework workshop where we are getting the data person there from WHO, who are going to get from the programs, the surveillance senior managers and the data persons, to try to understand from them how we can integrate surveillance and data together. Because why should you have different databases? You could have the same databases, and that can be collectively looked at. So very provoking questions. We will work on that. Thank you so much. Yes, Professor Nadira.
Thank you, Suman, for giving me the opportunity. Through my experience of working in this field for over 2 decades, the challenges that I would like to share. In Sri Lanka, as you know, we have Leishmania donovani causing cutaneous leishmaniasis in most cases. And we still use the traditional methods of diagnosis because the rapid diagnostic tests like RK39 does not work very well. So RDT would be very welcome in our case. Then when it comes to treatment, antimony, we use the sodium stibogluconate intralesional injections, which are given weekly. And the high resistance that we have observed is also a challenge. So, it's true that we are doing this clinical trial using radiofrequency therapy with help from DNDi. So I hope that will demonstrate the effectiveness of newer tools. So being open to new tools for diagnosis as well as treatment would be welcome, I think.
Thank you very much for pointing this out. And this is what we tend to forget is each country has their own specificities. Although it's Leishmania, and it's Leishmania donovani, but the behavior, as you see, is more cutaneous. We don't know if the same drugs work in the similar way in the countries. So I think we can have more discussions offline. I would like to thank all the panelists. Thank you so much for sharing your experiences. And we will come back to you and get back to you once we take the next few steps. And we would like to get your support in trying to frame the next steps together. Second thing is we will also try to summarize some of the important discussions which we had today, and we'll share with all of you. So if you are happy, you can share your emails to Aya. I know, Aya, you should take that. Huh? And then we will then keep on communicating. So there is a photograph which
Group photo.
A group photo, yes. So thank you, and please could you all join us for a group photo, Your Excellency and everyone. Thank you very much.
Yes, so I think everybody can go to the stage. Group photo, please.
So sorry, I'd also like to thank the panelists who was joined online. Thank you very much, Dr. Dal and Dr. Tripathi, for your contributions. Thank you so much.
Thank you, Dr. Suman. Thank you so much.